The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
As I said, I've been asked to speak about the role of universities in training people, and I sit in two worlds, so I'll try and sit in my university world and explain it from that perspective, but with a clinical application. So, I think probably the most important thing to do is, we're very mindful of it at the moment in Australia, is what's the value and the role of university education? So, some of you would know that the four big accounting firms, Deloitte, PC, EY, they are actually taking off the name of the university from which their graduates are being interviewed from, so that the old boys club cannot actually say, oh, he's a Monash boy like me, I'll have him. And what they're finding is they're getting a greater diversity of employees, and they're not using the name, they're actually really focusing on the skill. And the other part of that equation is that there is, it's not Deloitte, I think it's PwC, actually trialling employing graduates of high school, not university, into typical graduate jobs. They're actually saying, we don't see the value of a university education anymore, and we're going to try it. Now, it's unlikely in a professional field that that's going to happen, but I think it does highlight conversations around, do we think universities are delivering for our society what we expect them to? And interestingly, Australia, I think you would know, the university sector educating international students is our third largest export industry. So there's a lot of investment in our universities being at the level that we need them to be, not only for our own careers, our profession and the people we work with and our patients, but in fact the Australian economy full stop. What we do know is that there is no such course, no specific course for recognising and responding to deterioration, and I'm going to talk about that from a nursing perspective, but to my knowledge there is no medical course in a university that does that either. Happy to be corrected. What we do know is that our graduates, so those who come out with a Bachelor of Nursing, require support, experience and knowledge. They don't come out fully fledged. They are delayed in activating rapid response systems. They use intuitive rather than objective measurement. Is that a part of their hospital-based culture, or is it part of their university-based education? And that education and non-technical skills influence nurses' recognition of and response to deterioration. So in other words, they do have to be educated, and they do need well-developed non-technical skills in order to do this well. If you look at the Australian Qualifications Framework, so the AQF governs all of high school and tertiary sector, both TAFE and university. And at the moment, level 7 is bachelor degree. You can get anything on AQF on the website. Our postgraduate courses are at level 8, masters level 9, 10 is the top, and that's PhD. The I think it's EQ in the UK, Educational Qualifications, I think they call it. Having written curricula for universities, basically you have to meet the level of requirement. They have descriptors around that, and they have what's called a volume of requirement. And the volume is 150 hours per unit. And you then have to meet university-specific outcomes. In our degrees, you have to meet professional accreditation requirements. And in critical care, there's no accreditation. We haven't gone down that path, unlike nurse practitioner, midwifery and registered nursing. But we do have to meet discipline. Well, I've taken it upon myself as a course director when I was one to meet discipline specific. And we always used the ACCCN standards, and we were the only university around Australia that did so at the time. And competencies in those days, standards now, and we don't assess those, the hospital educators assess those. So I feel, and they have 100% in our model, our clinical staff, clinical agencies are the sole have the sole responsibility of passing or failing our students. So it's not us in the four walls of the university doing that, it's absolutely clinicians. And so they have to meet those hospital expectations. So if we look at what a Bachelor of Nurse program delivers for the ward nurse who's recognising and responding to deterioration, I know that they have a really solid curriculum. I also know it's completely inadequate because it's a 3-year curriculum, and when nursing moved in 1986 to the tertiary sector, which wasn't even defined as the university sector, which is why we have a couple of TAFEs now delivering nursing, is that they failed to get through a 4-year degree. It's a 3-year degree, and we know the complexity. I talk to my medical colleagues, they talk about the dumbing down and the reduction in hours of AMP in current degrees, and the students aren't as good. Well, we would argue the same thing in ours. It is evidence-based. They do get really good developed inquiry, critical thinking, problem-solving skills, and every single one of our students is in a hospital partnership and does 1 year of their 3 years in clinical. So a third of their degree is actually in clinical. What I think they're missing, and what I want to see more of, and this is a global statement, is interdisciplinary and interdisciplinary teamwork skills, advanced communication, written and oral skills, and particularly how to do that with patients and how to engage patients. But I think there's the other arm of that is actually how to do that with colleagues. Better clinical reasoning and interventional decision making, because I agree with Ken that I think probably a lot of nursing is around monitoring and then calling for help rather than acting, and we need to have them more proactive. We do much more of that in postgrad. And I don't think the research skills of our undergrad is good enough. Now, having said that, my colleague teaches in that, and she says it is rock solid. They do half a year on research skills. Everything they learn is evidence-based. They are to draw on it. But like all students, they choose what they focus on. They don't see the value in it, and they just don't do it. So if we're going to be provocative, and we might as well be because I'm amongst friends, then I think we need to change. And I want to show you what we did in postgrad that I think some of that could be implemented in undergrad. And that is take a really strong leadership with the discipline, with the clinical partners, and say, we want you to become really involved. So we have good, strong relationships with, so the university I'm associated with has 75% of the healthcare organisations in Victoria partnering with them to deliver our course. So it's not as if they are not influential or even directive. I mean, they're directive. And yet I think we can do more. So I do think this is our critical care one. We've added much more about patient quality and safety, I think, and TeamBased Learning, and my girlfriend is actually doing a PhD in students' acquisition of skills. I'm not going to do her justice, but of having completed postgraduate education, what is their understanding and knowledge and responsibilities around quality and safety, and that work will be out next year. She's just in final write-up right now. So a decade ago, I decided to rewrite a curricula, and I based it on quality and mastery rather than competency, and I set the expectations really high. So my experience with students is if you set a really high expectation, they'll actually meet it. If you set it low, that's the bar that they'll work to. And that happens because we are all time pushed and we all make decisions and we all behave in the same way. So there's behavioural things we need to get around as human beings. But if you make students do stuff, they'll do it. And they'll be grateful for it after the event, never during it. Have a backwards design, so I'm going to talk, university language here. You need to decide what the outcomes are that you want, and that's the first thing you decide. So once that's established, and therein lies the problem around MET training, for crit care it's easy. I know exactly what's required. I can then put in the learning design, set the expectations, and the last thing I do is set the assessment so that they are set before they graduate. Everything is aligned. In other words, what you say the student has to learn is what you teach, is what you assess. So our students don't come back to us and say, but we never learnt that, we never expected that. Everything's aligned and everything is authentic. So they have to have an authentic assessment where they're making complex decisions, where there's lots and lots of grey. And I can tell you the students hate us for that. But if we don't give them grey, when they get out there, they're going to be black and white. So they've got to learn to appreciate the grey and the muddiness and how to actually negotiate their way out of that with their colleagues and their patients. Make the learning really visible to students. So in an online environment that's often more difficult, you also have to give students immediate feedback. How much have they learnt? Most students don't know when they even get feedback. You have to tell them that is feedback because they don't know what feedback is or they don't know how to use it. You need to hold them accountable, and because we're in a system that it requires grades, we still grade them. The nirvana would be where the learning is achieved and it's not graded, but that's not going to happen now. All the assessment people think it can, I'm not convinced. And manage the risk, manage student resistance, because some of us like a free ride and we want the piece of paper without the learning. And that's the most important thing that we don't do, or every one of our qualifications is worthless. If your alma mater was delivering an education that you thought was too easy to achieve, what it does is diminish your own degree. So we have to maintain these standards. And then we have to have ongoing development for the staff, the skills, support it and evaluate it. So what we did was introduce a thing called team-based learning. Team-based learning emerged in the business school, but is taught in most medical schools throughout the world. Australia's probably the least, has the least adoption of team-based learning. In the US, you can't get a job in the university sector unless you're skilled in team-based learning. So we introduced this back in 2009. It's not group work. It's a very specific pedagogy that reverses a classroom. So it's not flipped classroom as such, it's a higher level than that. And what we know it does, and the research had told us, was that it improved learning outcomes. Students on average get about a 20% increase in their grade, assuming that a grade equals knowledge acquisition. Student engagement, their attitude to teamwork, and the teachers actually enjoy it too, because you don't have passive recipients like you are right now. So, as I said, it's not great work, and it's a teaching strategy that makes small groups of students become accountable to each other and remain accountable to each other in the same way that we are when we work in ICU. And it sequences learning. So rather than me doing the whole didactic, if I'm teaching balloon pump, they've done all the reading and the learning about balloon pump according to learning outcomes, and that's given 2 weeks prior to coming to class. So they have 2 weeks to get across that material. And when they come in, they are immediately assessed on it. So that's this phase 2. So here's phase 1. I'll go through it more slowly. They'll learn that material by work that we have set. So we are scaffolding their learning. So it requires a higher level of teaching skill, and it's probably the hardest teaching you ever do. In the second, we hold them accountable when they come in the room, and the students know, and 20% of them mark their final grades based on this. That can vary as much as you want or as little as you want, and there's lots of evidence about that, which I won't go into today, but they are immediately assessed on what they've learnt. So they get immediate feedback. They then take that same test with their colleagues. So they're in the same team for the whole year, and they take that again. And so what they learn to do, is they learn team formation, so the learning, forming, storming, performing. And so when you see the students in the first week, they'll be voting on which they think is the right answer. They soon learn that it's not about the vote, and they have to understand their reasons for it, and they've got to give physiological or evidence-based reasons for it, because they then, in the next phase, have to stand up and own their decisions and speak out loud. So in the third phase, they all answer an application. So it's a very difficult clinical scenario where there is rarely one right answer. We write them so that there's not one right answer. It's the best answer. And it is the nature of the power of the team to solve it. So they learn that the individual doesn't matter so much. They also go through a process of peer feedback, because I think most of our colleagues are pretty poor at giving it. They're also pretty poor at receiving it, and they learn how to do that. I'm going to skip through this very briefly, and that is, the research shows from our studies as well that from the classroom to the clinical setting, our students are far better equipped. They get really deep learning, they get a lot of confidence, and they develop all the clinical and professional behaviours that we need them to have. So they get mastery of their specialist knowledge as opposed to competency. They have much more confidence in dealing with people themselves as a professional, and patient advocacy. They develop the professional leadership skills and multidisciplinary communication skills. I'll add, I don't think that's perfect yet. and they are able, I think, to develop what are these other generic soft skill outcomes that most universities have. So, you know, we all know that whatever discipline you do, you've got to learn that. But it's the rest of that list of 8 that actually makes you professional and ensures that you have lifelong learning skills. Lastly, I want to finish up, and I've sort of inferred that I don't think we teach our students communication skills enough. And you'll know that there's a centre in Harvard and there's a centre in Cambridge, and at Deakin we've started a centre about organisational change in person-centred healthcare to actually deliver our colleagues more communication skills and keep that going. So I think that the better that we can get our colleagues out of our undergraduates skilled in communication, they'll be better at responding and recognising deterioration. I'm going to finish in half a second, Sam. So I would conclude with, what's the role of university? Setting the baseline, setting the expectation that the student has to learn for life, beginning their professionalism traits and hoping that that's carried further into the hospital sector, and ensuring that we deliver a system where their professionalism and their communication skills can continue to develop, because we know that helps save lives. Thank you.